Good morning, everyone. It is 10 o'clock and it's time for our weekly coronavirus virtual information session. I want to welcome you all on behalf of the Traeger Institute. My name is Anna Ford, the Executive Director, and we have, again, an update that we're going to get from Dr. Furman, our Medical Director, and then we're going to have a guest speaker, Dr. Paul McKinney. Just a few ground rules. Please mute your mics, keep your video off if you don't want people to see you when we record this video, this session. You can type your question in the chat or you can raise your hand. We will alternate between the questions asked via the chat and the raising of hands. And then I want to make sure that we hold all the questions until the end so that we can just get through the speakers, and then we will open it up for any questions. And then lastly, if you can go to the next slide, we want you to just make sure that if you do have difficulty with your sound, look at that button there. That's where you can go to get your microphone set up. And then if you can go ahead and type the county in the chat room for us, from where you are, it helps us to determine our reach and how we need to make sure we keep staying relevant for everyone who signed up for this call. Thank you very much. That is it. And with that, I am handing it over to Christian Furman.
Hi, everybody, and welcome to another week. Every week is a challenge. So I just want to kind of give a few updates. The big thing is that I want to remind everybody, if you have symptoms, the symptoms of coronavirus are cough, fever, shortness of breath. But what we're also finding is we're seeing people with diarrhea. Sometimes a smell, you can't smell, you can't taste. Sometimes it's a sore throat, sometimes it's just very tired. Definitely contact your primary care physician or provider, physician or nurse practitioner or medical assistant. And all the practices pretty much are going to telehealth and teleconferencing so they can address your concerns and figure out how to treat you. We do have, through U of L Health, the drive-through testing. And so if that's something that your provider thinks that you need, they can set that up and you'll get an appointment for the testing. So also just a reminder, every day at 5 p.m., the governor, Andy Beshear, has an update. So I'm not going to give the update on the numbers and all the details because he does that once a week. Every day at 5, even on the weekends. And then also the big thing that's going to happen this week, I think, is the nursing homes really deciding. A week ago today, U of L Health went to a universal mask policy, so everybody's wearing a surgical mask in all the clinical areas. And so since we do have enough cases in Louisville, we're asking, sorry about that. We're asking all of the nursing homes to wear the mask also if they can. But what's happening is a lot of the nursing homes do not have the surgical mask. They don't have enough of the equipment. So if anybody has, just mask at home, some people have it for cleaning, or if your company or your teacher in your school has the mask, surgical mask, or N95 mask, if you could drop those off at your local nursing home. The nursing home needs masks. The nursing home needs personal protective equipment. They need the gowns and they need the gloves. So we really would encourage you to drop those off at your local nursing home if you can do that. And so then I'll be available at the end for questions too, and then I'll turn it back to Dr. Fall.
Thank you, Christian. And now we're very excited to welcome Dr. Paul McKinney from the School of Public Health and Information Sciences. He is Professor and Associate Dean for Research at the school. He also serves as the Director of the University of Louisville Center for Health Hazards Preparedness and the Commonwealth of Kentucky Local Performance Site for the Health Resources and Services Administration Region 4 Public Health Training Center. His prior experience in the field of public health includes service as an Epidemiology Intelligence Service Officer with the Centers for Disease Control and Prevention. He also served as a U.S. Public Health Service Primary Care Policy Fellow in Washington, D.C., where his focus was on the development of policy regarding the threat of bioterrorism against the United States. Since 1998, he has been a liaison member of the CDC's Advisory Committee on Immunization Practices, representing the Association for Prevention, Teaching and Research. He also served as project director for the University of Louisville's Bioterrorism Training and Curriculum Development Program. And he was co-principal investigator of the Pandemic Planning and Preparedness Program funded by the Department of Homeland Security. He's a board certified in internal medicine. He's a fellow of the American College of Physicians and a member of the Alpha Omega Alpha Honor Medical Society. And we are really fortunate to have him here today to talk a little bit with us about lessons learned from the Spanish influenza pandemic of 1918 to 1919. How does that relate to this current pandemic? Dr. McKinney, thank you very much for being with us, and I hand it over to you now.
Thank you, Dr. Fall. And can you hear me okay?
Yes, we can.
Yes, okay. Very good. Thank you. So the parallels between 1918 and the current pandemic of coronavirus infection are really quite striking. There are actually many ways in which there are stark differences as well. So maybe I'll give you a little overview first, and we'll kind of touch on both of those points. First of all, the world in 1918, of course, in the spring of that year, Europe and the US were both engaged in World War I actively. And we had troops in training across the country in various places. And in fact, that was the first site of known infection with the strain of influenza in 1918 in the US, was in a military camp in the spring of that year. There were a relatively small number of cases, March, April, in that time period going into the summer. Things kind of dwindled out, and probably what happened was the virus was introduced at some point into the combatants in the war, and was amplified over there in Europe. And then in the fall of that year, starting actually in August, but into mainly September, October, with returning troops and movement of personnel from Europe back to the US, the major portion of the epidemic hit the United States. And by that time, we were in a global pandemic as well. So where did that virus come from? And we're talking about not a coronavirus, talking about influenza virus in 1918. Nobody knows the ultimate origin of that virus. There's speculation, as there is evidence this time around, that China may have been the source. We don't know ultimately what the exact source was, but there are clearly concerns about how the virus did get reintroduced into the U.S. in the fall with regard to movement of people without restriction, basically. And what happened in the latter part of 1918 was that every state, every city pretty much was designating its own policy with regard to movement of people. So if a ship came over from Europe with people who are sick and obviously having influenza-like illness, it was up to largely the authorities in that port in New York and Boston and Philadelphia to decide what to do. And consequently, there were different responses, and there were different ways in which the pandemic played out in different parts of the United States. We talk about the cessation of activity here with regard to sports, for example. All the sports activities are on hold. The World Series of 1918 went forward. As usual, it was between Boston and Chicago. And the only difference was that there was an advance in the time. Instead of being played in October, it was played in early September, which was fortunate because it got things out of the way relatively early. But probably the main impact was felt by the city of Philadelphia early on, because at least in part, in major part, because of a very large parade that was held to support war bonds in the U.S. and a drive to commit additional funds to that campaign. There were perhaps several 100,000 people on the streets and in close contact, and a spike occurred right after that in the city. Other communities across the country reacted differently after that, some closing down public parades and things like that, and others going so far as to closely approximating what we have right now in many parts of the U.S., which is almost a total shutdown. Schools, churches, restaurants, other public activities. But the differences are striking as well, because this was not a coronavirus.
It looks like this is Christian Furman. This is Dr. Furman. It looks like Dr. McKinney.
Yes.
Back. You just cut out for a little bit, Dr. McKinney.
Yeah.
So maybe go back 1 or 2 sentences.
Oh, okay. Sorry. With regard to influenza and the difference between influenza and coronavirus, we had a limited information or knowledge about what viruses were in 1918. We certainly had no antiviral agents of any sort. We had no vaccines that were ever available against influenza of any type. And so the only real effort that we had to counter movement of the virus was restriction on social activity. So, and the consideration of the use of masks when people were in public. And that's another interesting point, is that, masks were adopted in various places, especially by the workforce who had to remain on duty, like the policemen, people who operated the train systems and subways and so on. And of course, physicians and nursing staff in hospitals, you would see that utilized a great deal. Some communities had mandatory requirements for masks, especially as the disease progressed across the U.S. and eventually hit the West Coast. San Francisco mandated the use of masks in public. You could not appear in public without wearing a mask. And what kinds of masks were available? These were largely homemade types of devices. The U.S. was still on a war footing and geared up to make masks, but these were primarily gas masks that were used in the trenches of World War I. We didn't have very much production of surgical type of masks, very, very limited. So people were advised to use gauze, for example, to formulate a mask, or to create one out of other materials, sort of on a home basis. There was no large-scale production of masks in the U.S. At that period of time. But in the places where they were used, they may have been somewhat effective anyway in curbing the spread of disease. And of course, now we know, and as Dr. Furman mentioned, we're adopting a policy of more widespread mask use in the U.S. This because of the fact that there are probably so many people walking around with unrecognized infection who might be transmitting it unknowingly, and if they had a mask, that would potentially at least absorb a lot of the droplets that would otherwise enter the air and transmit infection. So why don't I just stop there and see if there are any questions so far, or any comments about what I've said.
This is Dr. Furman. Do you know, I've heard different stories why it's called the Spanish flu. It didn't start in Spain, I don't think, from what I heard.
No, it's a great misnomer that didn't originate in Spain, of course. The reason it's called the Spanish flu is that's where the information emerged first about the infection, because the powers that were actually engaged in World War I, France, UK, Germany, the US, were all under censorship. That kind of information would about a virus that was circulating would be contrary to the war effort, so that was suppressed. Spain was not a combatant in World War I, so they had a free press, and they were able to describe exactly what was going on in their country. So all the information that was emerging about the virus really was coming from Spain, and that's how it got the name Spanish influenza.
And sorry, this is Dr. Furman again. I did also hear that it seemed like there was a first wave of the virus, and then it kind of got suppressed in the summer, and then like a second wave came in the fall. Is that true or no?
That is true. In terms of what the U.S. experienced, yes, there was a decline in the U.S. after the spike in military facilities in the spring of 1918. Not much activity over the summer, and then with the arrival of ships from Europe starting in the late summer, early fall, that's when it really hit and spread across most of the population. It was really a military disease in the spring of 1918. It was a civilian disease in the fall of 1918. And the number of deaths in the US ultimately, just to give you a sense of proportion, the number of people who died in the US from influenza was 10 times the number of people who died in the war as casualties of battle. So the impact was enormous. It was staggering. And, the stories that have emerged are kind of legendary. I mean, I heard first about Spanish influenza from my own father, who was living in New York at the time. He was probably about 11 years old, but still remembered the impact in the city, and how there was evidence in all the neighborhoods of families who were affected by deaths. People had the habit in those days of hanging crepe, and that's a term that we hear periodically now, but it was a practice in those times that people would hang crepe in the outside of their house to symbolize somebody had died in the family, and that evidence of that was everywhere. The effort to handle the excess mortality was at a level that had never been seen before, and probably not seen since until now in the New York City area.
So I have another question that's related to the wearing of masks in public. So we know that the CDC are recommending that when you go out, you protect yourself, but we also know we shouldn't wear the masks that is required for people in the medical field. Do you have any suggestions for what would be a good protective masks to wear in public?
So, for individuals who have higher grade masks that are industrial strength and so forth, we want those in the hands of the medical professional. So as Dr. Furman said, if you have materials at home that are designed for high level use and so on, make sure that the ones who need them on the front lines in either nursing homes or hospitals
Thank you.
get a chance to get them as the production ramps.
Because they will be, this is Dr. Furman, they will be making more masks, and so I think right now it's just a timing issue. So if people do have these masks at home, donate them to the nursing home, donate them to the hospital, because you can use your own homemade mask, and then everybody eventually I think will have enough masks because they're going to make more. But
very true. I think for right now, using a cloth material that you can form at home, a porosity to it. You don't want something with gaping holes, obviously, in it. You want something that fits across your nose and your mouth and covers that completely, and that hopefully forms, a relatively, not fully tight, but a really good, fairly good seal around your face, so there's not gaping holes in there. And the main thing is, for these types of masks that are not to be used in a medical setting, you want it to be able to catch droplets that may be coughed out or sneezed out by people. It's not going to be a super secure device that you would use in a hospital or nursing home setting.
Okay. There's some questions from the chat. Justin, are you going to read them?
Yes. So Barbara asks, from an epidemiological perspective, what are your thoughts concerning the U.S. experiencing multiple waves of COVID-19? Multiple waves
of COVID. That is obviously one of the biggest concerns at the moment, that the virus may well fade out, and we expect it to over the coming weeks. But what's going to happen after that? Will there be a second wave? That's what China has kind of been bracing for. That's what all the authorities at the CDC and NIH are worried about. We would love to have a way of determining who may be immune and to enhance the development of immunity among the population. We need to have, obviously, a vaccine as soon as possible, but realistically, we know it's going to take maybe a year or so to develop that. We've never been able to push a novel vaccine out any faster than that. Yeah, major concerns, and so the big way we're going to try to deal with that is to develop tests for immunity and look for antibodies that may develop, and to do widespread testing of individuals as well to find out who is infected.
Okay, and someone asked, should immunocompromised people be taking any extra precautions with regards to their masks? They've heard that the masks are just for comfort and don't really do a whole lot for mitigating disease spread.
I wouldn't say the masks are just for comfort. And I think that the best thing that if people have a serious immunocompromising condition, the best thing they can do is to avoid being in public, period. And if they have specialized needs, I don't know, a bone marrow transplant patient or something like that, and that person might be traveling back and forth to a medical facility, that person should have a specialized mask for moving around in those settings. That's a different story. That's not the general population. That would be rather unique and very small population of individuals who have specialized needs.
And Scott asks, were the public health laws in 1918 different than now?
Well, the public health laws were primarily those that affected immigration at major ports, at the federal level, and then at the local level, they were highly variable. So, I mean, when you look at the response in 1918, there was really not any significant large-scale federal response to the pandemic. It was all a state by state and municipality by municipality response. The Surgeon General made certain recommendations, but there was no formal policy. You didn't have the President of the United States, Woodrow Wilson, getting on television because there's no television, and in fact there was no commercial radio in 1918, so there's no radio addresses across the nation. All you could do was have printed pronouncements, and that was really not coordinated at any significant level. So you would find high degree of variation, as I said, from state to state. There was no passage of special laws on a national level to do this. There was no restriction of motion. There was no new immigration policies passed. And every locality was for themselves predominantly. I have to say that the other thing I didn't mention about the disease in 1918 was that the population that was affected primarily was younger individuals, people in the 20 to 40 age range. The very young and the very old did okay. President Wilson was said to have gotten infected with the virus. He developed the flu, but it was a relatively mild case. He would have been in his 60s at the time, and so probably had some pre-existing immunity to the prior strain that circulated of the same type, of the H1N1 type that the Spanish flu was. So he did fine until later in the year. He was, 1919 rather. He developed a major stroke, but that was not related to the Spanish flu, which he had a mild case of in early 1919.
So someone asks, for people living in rural areas that are quite a distance from larger hospitals, if people become symptomatic, would it be better to and that requires medical attention, would it be quite better to go to the rural county hospital or go to a larger hospital in the city?
Well, it's a somewhat difficult question to answer. I would think that what you want to do is to go to your local facility in almost every case, unless there's some highly specialized need that required secondary or tertiary level medical center. If you're just an average case of coronavirus infection or suspected infection, don't travel any excess distance to get care. Go to the closest place that you can and make sure they're aware that you're coming. The things they're going to be providing for you, at least the first line, is to check your vital signs and your oxygen level to see if you need additional oxygenation. Now, the one thing would be if certain very, very small facilities may not have either an intensive care unit or ventilators, possibly, but hopefully they'd be able to transport you rapidly should you require that. So I wouldn't advise people to migrate from the outlying hospitals into major cities. That's just going to increase congestion at the larger hospitals. I think you need to go to your local facilities and let them handle you first.
Right, and this is Dr. Furman too, and the local facilities are all equipped. I mean, they've all had the training, and they know when to escalate. If they can't handle it, they will transfer you. So yeah, that's what U of L is recommending, is to stay at your local hospitals, because you're right, we can't handle all the people if everybody goes to U of L.
So there's another question about, in a book called The Devil's Flu, basically it states that people who survived the Spanish flu were highly unlikely to have the flu again, and they seem to pass the immunity on to their children. Is that something like that happen with COVID?
Passing immunity onto their children. I'm not really sure what that means. There's no, genetic way in which you pass on immunity to a virus which you're exposed. And there's certain hereditary factors that make it more likely that you'll be able to mount an immune response. Unless you're talking about maternal fetal transmission, so if someone, if a child is born to a mother who has had an infection, they will at least temporarily have protection passed across the placenta to the developing fetus and to the newborn infant, but that's short-lived. That won't persist throughout their lives. There are obviously genetic factors that are going on in the current coronavirus that we don't understand. We're seeing, entire families that are affected and a large number of deaths occurring in certain clusters like that. We're seeing high incidence of mortality in people of certain ethnic backgrounds and don't understand that. Why is Italy having such a catastrophic death rate? Don't really have a great handle on why that is, but there are studies that are ongoing right now. We're trying to get genomic data from Italy and elsewhere to try to figure out what this is exactly. Is this related to their HLA type or other immune factors that are going on, or is this something else? Does it?
I think Dr. McKinney is delayed again, so
we can protect people.
Next question, Justin.
What do we know about asymptomatic patients? What is the timeline? These people are contagious. Do these people test positive? And is there a blood test that can let you know if you have it?
Well, we don't know enough about asymptomatic people and their duration of risk. We do know that people who are asymptomatic are able to transmit the virus. We don't know to what level, if they're as effective in transmitting, probably not as people who are actively symptomatic, but based on all the modeling and all the studies done to date, pretty good evidence that these people are actually part of the transmission cycle. And they need to be, the fact that they are is the whole reason why we're on community lockdown. We don't know who's got the virus and who doesn't yet because of limitation of testing. So that being able to do a large-scale community testing of asymptomatic people to find out where the reservoirs of the virus are will be very helpful to us, and also the upcoming antibody tests to tell us who had the exposure, who has immunity, will be critical as we begin to emerge from the pandemic.
And this is Dr. Furman. I saw that Dr. O'Brien's on in the chat and said that, our state is doing, let me just see exactly what he said. Justin, do you have it? I think it said.
He said he just left Florida a week ago, and it was unimpressive attempts to contain the virus. Beaches were full. He said Kentucky, especially Governor Beshear, is impressive.
Yeah. Yes, I think, everybody, we are doing a good job of flattening the curve here so we don't overwhelm the hospitals. I think, it sounds like we'll probably have the peak here will be about May 4th to 5th. But the next 2 weeks are essential because, people are out and we want to keep people in. So we're really, everybody needs to be healthy at home. And so I think our governor has really emphasized that, and especially with, Easter and on Sunday, and there's services all week and different things going on during the normal life. We're not normal now, so we can't do normal life. So, everybody should stay at home and not get out at Easter. Even the 6 feet away, people say, oh, you can still keep 6 feet away. But what happens is you just get together and your instincts come and you don't stay 6 feet away. So it's best not to even get together. And that's what the governor's really emphasized. And I want to reinforce that people should just stay at home.
Yeah, I certainly would. I would second that statement. And if you're getting together for a holiday and you're going to have a meal together, you're going to be sharing utensils and sharing, you'd be touching either food items or containers of food items. And so there's a whole range of ways in which you can spread the virus. It would be impossible in a family gathering to probably maintain any kind of reasonable distance for any time period and not to transmit the virus via contact with other inanimate objects. So yeah, there's really a good reason not to have those kinds of gatherings over this upcoming holiday weekend.
And even outside, people think, oh, I'm outside, it's okay, I'm not going to touch anything. But human nature takes over, and people make mistakes, and those mistakes could lead to loss of life. And if it's not your own family, then you pass it to somebody else, and so it's just not worth it. Do not get together.
Yeah, I mean, really, that's the only way we have of limiting transmission of virus right now is limitation of contact. And if we don't do that, we are risking major prolongation of the virus in the community at the present time. And then, we certainly, if that continues too early, if it begins to resume too early, we're going to risk reintroduction of the virus. So we have to get used to this as the new normal for right now until there's an important breakthrough.
So two-part question. Is Kentucky's apparent above average flattening just a result of low testing numbers and low access to testing, or actually are we showing a positive impact from social distancing? And the second part, can you speak to the commentary that the death rate is being underreported because people are dying at home who haven't officially been tested or diagnosed?
Yeah, with regard to the last question first, I think there is concern that there's some underreporting. We don't know to what degree that underreporting exists. It probably is most severe in communities where there's a very heavy volume of disease, like in the New York metropolitan area. I'm not sure how you could accurately count, all the causes of death there. And not everyone's gonna be able to get to the hospital either. And certainly people have died before making it to the hospital, and I'm not sure how those types of deaths are being recorded. There's a lot of uncertainty. And we may be seeing only a portion of the iceberg here. There may be a large number unreported, but that's the degree to which that's happening. We don't know exactly. We just know it's almost certainly happening. In the state, are we actually flattening the curve? We're just not testing. I think there is some under testing in the outlying parts of the state, the more remote parts of Kentucky, in the Louisville area. We've got actually a very good testing capability. We don't know everyone, obviously, who's got a virus because we're not testing the entire community. But I think anybody who's got symptoms is going to a healthcare facility, they should be able to get tested and tested rapidly here. I think the numbers do reflect the fact that we're having an impact. We're going to have to see sustained efforts, though, for that to continue. We can't just relax what we're doing and say, hey, we're doing a great job, we can just let up. That would ruin everything. We have to continue what we're doing and even double down some more to make certain that we, in fact, achieve the kind of better outcome that the governor has designs on for us.
And so, PC, if I don't frame your question right, just message again and I'll see if I can get it better. But you recommended that residents should go to their local facilities for care at this time. If they had physician visits with out-of-town physicians instead of their local, should they keep those appointments? And how should a patient decide which appointments they should keep and which they should reschedule? Yeah,
I think that any purely routine types of appointments for just a simple checkup, I wouldn't recommend anyone drive any distance to do that. If it's a highly specialized visit, where you're going to somebody who has responsibility for treating a rare disease that you have or something like that that nobody else can do. I mean, obviously, we wouldn't tell you not to go to that kind of, to travel to that kind of appointment. But if you're talking about, I'm going to somebody further away who is going to test my blood potassium level and check my blood pressure, well, that can be done anywhere. And if that needs to be done, you should be doing it at the closer facility rather than at a distant facility. And decide whether it's safe to even postpone the visit altogether, depending on whether it's purely routine or something that is following an active problem that needs intervention.
And this is Dr. Furman. Pretty much every provider has gone to telehealth. I mean, across the world probably, but definitely in Louisville and our surrounding areas. So if you talk to your provider, they will set up a telehealth visit. And if you don't have the technology for telehealth, we can do visits now on the phone, and Medicare is paying for that, and all insurances are paying for these just phone calls as regular visits. So really no one should be leaving their house for any reason, except like you said, Dr. McKinney, if it's specialized. But even if it's specialized, you call your doctor and they can do a lot of it over the phone or through telehealth. So I would recommend everybody, and what we were doing at first in our clinic was we were just pushing all the appointments out. But now we're like, we're here, we're doing telehealth all day, we might as well just keep the appointments. So we're keeping all the appointments, but we're just changing them all to telehealth. And so that way we can keep people, and a lot of people just need to check in because everybody's anxious and nervous and has a million questions. And that way you can get your individual appointment with your provider and answer all those questions and help people understand this disease and understand the virus. So we're changing all of our appointments to telehealth. So we're keeping all the appointments, but we're just changing them. So just, each provider is different, but yeah, I agree. You don't want to be driving all across the state trying to, talk to your doctor if you can avoid it.
I would definitely agree. And, to the extent that telehealth is available, obviously you want to use that whenever possible. And there are situations that come up where you need to get a blood test, though, and you can't do a blood test via telehealth. So if you have to get, a blood work done, if it's required, clearly then you don't want to travel any further than you need to. And decide based on your discussion with the provider about whether testing is truly necessary or whether that can be deferred also. So discussions will continue about necessity for care, and the care that's required, we'll figure out how to do it, and to do it in the way that requires the least exposure of the healthcare workforce and hopefully the least consumption of at least fewest miles traveled to make that visit. And if things can be handled over the phone and don't require testing, that's even better.
So someone asks, when on the curve will it be safe to move around?
The answer that everybody wants to know, and we don't know, of course, what that is going to be. Once we have the ability, to do widespread testing, either of the virus itself, the current test, which is a test for the viral RNA that's present, either have that, or if we have a reliable antibody test, then we will know when it's safer to move around. But until that information is forthcoming, we're just shooting in the dark. We don't really know. Anything would be total speculation. And just to see a drop in the number of cases, and actually even 0 people coming in with the virus with infection over a period of a few days would not be reason to just open up the community again for business all of a sudden, because there are the asymptomatic folks out there. And we don't know how many of them there are. We don't know where they are. And so we need the ability to find that out, and to find out who actually has durable immunity also. If you have that information, then we'll know when it will be safe to reopen activities.
Any other questions from anyone? Seems like we have answered all questions.
There's one more that just came through. Is there evidence of people who've experienced COVID-19 being reinfected?
Well, I certainly have heard reports of that happening. I don't know of any actual verification that that's true. There are situations where people are recognized to be infected and then seem to do well for a few days, and then days afterwards get worse. Is that the just the course of the original infection? Probably so. Like, look at Prime Minister Boris Johnson was relatively well for several days after he was found to be infected, and then now has some more serious problems. That's not reinfection. That is continuation of the same infection. And people who recover from illness can have persisting, in some cases, they can still be positive if you re-swab them for the virus, even a few weeks out. So that's a concern. And is that a reinfection, or is that persistence of the same virus that's not fully cleared? So, the difference between getting the virus a second time and being persistently infected, that's something that we haven't sorted out yet. So I'm not really clear that there's a major concern about reinfection. It certainly may happen, especially with people who have immune system problems. But I don't think that's going to be a large-scale concern.
There seemed to be another question. I'll just read it. Does it appear that this virus can be an annual seasonal illness that we need an annual vaccination like with the flu shots?
It certainly could be. This virus may be something like influenza, where there'll be some, antigenic drifting or, shifting over time. We just don't know. There's not enough experience with it. But all the experts seem to say there's a concern that's going to be a seasonal virus. It will keep coming back, and that will, in order to really suppress it, we'll need to have a solid vaccine that will be available, and to provide widespread immunity of the population. It may be that at some point this virus will just disappear the way SARS did. The original SARS virus was raging in the spring of 2003, especially in March. Canada was ravaged by SARS. Lots of cases there. It disrupted the entire healthcare delivery system in Canada for several months. But by the end of June, the virus was essentially gone. We don't know what happened. It disappeared for reasons we don't entirely understand. We're not saying that's going to happen with the current virus. We're not expecting that to happen, because this is a different scenario entirely. But we don't know. There's a lot of uncertainty, clearly, because this is uncharted territory. It's a novel virus. We don't have experience with this one before. But we can't write off the fact that there's going to be another wave coming at us in the fall. That's still the underlying concern.
And I think that kind of goes into someone's question about it being, how will we know if it's going to be an annual illness that we need an annual vaccination like the flu shot?
We'll know from how the virus reacts, how we see the virus resurge. If it does, we won't know if we're going to need it until we see what happens. And there's no predicting, there's no model that can tell us if that's going to happen or not. It's just, we know too little at this point to really do more than simply guess. And I think we have to take the side of caution here and not just say, well, SARS went away, this virus is going to go away, so don't worry about it. We can't have that attitude, because it could really come back to bite us in a major way. And we need to be prepared. And if it doesn't resurge, fine, we've done more than we needed to. But nobody can be confident that there's not going to be one or more waves yet to come.
And someone commented there's I guess news floating around that there were respiratory illnesses in December that may have been COVID-19. Is there thinking that COVID-19 was present that early? And if it was, why isn't there a bump in respiratory hospital admissions at the time? So is there any validity to that story?
No validity that I know of. There was evidence that the virus was present in China probably at the end of November. We don't have any such evidence here in the US of non-influenza outbreaks, anything on the level that we're seeing right now. I would strongly doubt that COVID was in the US prior to 2020, prior to January, late January, early February, somewhere in that range. I think was the earliest time that we can say that we expect the virus actually appeared. And anything beyond that is speculation. Perhaps antibody testing of people will help sort that out somewhat. But if we have stored antibodies on people and can test and see if anybody has an antibody level prior to January of 2020 based on serum that's stored someplace. But I doubt that will be the case. I think the virus is, appeared here when we recognized it, or shortly before that, probably sometime in the latter part of January.
And so this is sort of a two-part question, a question from the chat and my own personal question. Why are children not seeming to be as affected? And when you compare 1918 to now, are there differences in the symptoms that would affect different age groups? How does that, do you have any idea on how that works?
So the answer about why kids do relatively well and adults don't do as well, especially the aged, elderly people who, I'll just use the term over 60 individuals. How about that? So why do individuals over 60 not do as well than people in the middle age groups and younger people? The answer is don't know. It's not anything to do with pre-existing immunity, because no one's ever seen this virus before. Is it something related to the immune system? Almost certainly, but in a way we don't know. That's one of the areas that's under most active investigation at the present time, to see if there's something about, could there be a factor related to other coronavirus exposure? We know that there are 7 different types of coronavirus, right? There are the MERS virus, the SARS virus originally, and the SARS coronavirus 2 that we're seeing now. Those 3 are the bad actors. There are 4 other strains that cause upper respiratory infection in humans. They've been around forever. They've circulated for a number of years. Is there something related to prior exposure to those other strains of coronavirus that may affect the ability to respond, that either enhance the response to the current coronavirus or alter it? We don't know. Those areas are being looked at quite actively right now. Is there some, area of the immune system, our ability to respond with interleukins and so forth, areas of immune modulators that are different in older people? Very important questions, very interesting ones. We just don't know. We do know what explained 1918. We do know that there was a prior strain circulating in the US in the late 1800s that older individuals would have been exposed to, they would have had pre-existing immunity to that H1N1 strain that would have helped protect them. That's why the elderly did not suffer the worst consequences. It was the younger individuals, younger healthy folks in the 20s, 30s, and 40s that were the primary targets of the virus who suffered the highest level mortality. So whole different scenario now with what's going on, and trying to sort out that whole question of why some people and not the others is going to be a major question that we have to uncover. We have to resolve that before we can work our way out of this entire situation.
So Julie is reading plasma with antibodies of patients who have recovered being used as a treatment. Is this being studied as an option?
Yes, in fact, it's being looked at even locally. It's being looked at in experimental animals that are being studied in the lab here, and it's also feasibility is being looked at in humans as well. I know in New York City area, it's already being tried in at least some number of folks, probably a low scale intervention, just because they don't have tons of immune plasma or serum that they can use. But once the number of survivors increases, and you have to have people a certain number of days out after infection so that you're confident they're not going to have any virus present and so forth. Once we have that amount of plasma, we'll see if that works. It probably will work. It should work. We just don't have enough of it right now. And unless we can develop synthetic antibodies at some point, it's just hard to produce enough to be utilized on a wider scale. But studies are ongoing, particularly in the areas hardest hit right now of the use of plasma from recovered victims.
So there appears to be confusing reports of animals getting this virus. What are your thoughts?
Yeah, I'm hearing a lot of different things. I think the one thing to remember is that there's no concern that animals are a major source of transmission to humans. It's very possible that some of these animals, like there's a tiger in the Bronx Zoo or whatever, maybe infected. They could potentially get infected from humans, but no one has suggested that transmission from either our pets or zoo animals to us is going to be any kind of major concern for continuation of the pandemic. The virus originally got into humans, probably the most widespread theory is through the live animal markets in China, that there was some commingling of exotic animals from the wild with domesticated animals and they being sold in the markets and so forth. And it got the virus mutated and was adapted to humans in that setting. Nobody knows it for sure if that's correct, but that's the most widespread hypothesis right now. But in terms of either our pets or zoo animals spreading it back to us, have not seen anyone who's worried about that or concerned that that's going to be a major issue going forward.
So a question about the federal government statement encouraging patients to ask for, and I'm going to butcher the name, azithromycin.
Azithromycin, yeah.
And then the hydroxychloroquine. Yeah, thank you. Yeah. So as prophylactic, any thoughts on that?
Well, that needs to be studied, and it is being studied. There are actually a number of different clinical trials underway. I know the president's advocating its widespread use. I think that the scientific community is saying, let's study it and see if it works. Now is the time to do clinical trials, whether it works prophylactically to prevent acquisition or suppress the virus, or whether it works to actually clear the virus more rapidly in people who are infected. We will know the answer to that hopefully fairly soon based on what's ongoing. There are a few reports in literature. They're limited. The trials are flawed. They're not perfect studies. There are concerns about the methodology, but the ones being done here hopefully will be structured much more strictly, and in a period of a month or something like that, we should be able to get at least some preliminary data from those types of studies to give us some direction in this. But to say that everybody automatically should be on those drugs, I don't think we're anywhere close to that currently.
And this is Dr. Furman, and the American Medical Directors Association Post-Acute Long-Term Care just had their annual meeting virtually on Thursday, Friday, Saturday. And they said for sure in the nursing home population, we do not want to use those medicines because they have side effects. And older people already, you know, are at risk with their kidney function. And so they're recommending not to use those medicines. Plus the other issue is like, if everybody uses them, they're going to run out of the medicines for the people that maybe really, really do need them. Like this probably should just be used in the hospital. If you're sick enough to be in the hospital, okay, maybe you're sick enough to need those medicines, but just the general population using it, we won't have enough medicine. So you're right, Dr. May, who knows right now, but do not take anything without talking to your provider. Your primary care provider should look at all your medicines and see, you know, everybody's individualized, and it can hurt you just to take random medicines.
Yep, very true. I think that the idea that anything that you could consider using in a previously healthy person should be adapted for, you know, the nursing home population is you know, absurd. There's so many things going on in that group. So, polypharmacy issues, other drugs you're taking, other conditions. We just don't know as much information about how those drugs will work over the longer term in that population. So trying to, you know, implement a widespread change in therapy based on a hunch is just not a scientific way to approach things.
And then there are many faith-based and other well-meaning folks who want to help by making homemade masks out of cloth. We know these cannot be used by bedside staff, but do you see any use out in the community?
Well, if they're constructed in the right way, and again, you know, such that the material is not too porous. You don't want big gaping holes, obviously, in the material, and you want the mask to be able to be secured around the face so that there's, you know, pretty good coverage, both the nose, the mouth, and there's not any areas of, you know, where the mask is open around the face. It should secure around the contour of the face. If that can be done, you know, for the average individual, you know, walking around, if they have to go to the grocery store, for example, and make a purchase of some needed item, and they're going to be, you know, unavoidably closer than they want to be to somebody else, that should be fine in those settings. And it would be best if, you know, everyone did that, because the masks that we wear in those settings are probably more important for other people than they are for us, because they may not be able to protect you from inhaling the virus, but they should help prevent you and other people from propelling large spray of droplets into the environment. So that probably is the major way in which those masks will help.
Thank you. Thank you, Dr. McKinney. This was a very lively discussion. It took us a whole hour. This was our longest session. And we can see that people really were interested in this topic. And thank you so much for your valuable information. And it was just wonderful. People are responding that it has been a really great hour. Thank you so much for everything.
Thank you. I appreciate it.
And we will see you again next time.
Everybody stay healthy, stay at home, and have a happy Easter and have a happy holiday. Wash your hands.
Thank you.